Order. I call the meeting to order. This is the Standing Committee on Health. I'm John A. McDonald, the MLA for Hants East and the chair of the committee. Today we will hear from witnesses regarding barrier-free access for contraceptive and sexual health services, including PrEP for Nova Scotians. As a reminder, please set your phones on quiet. The mics for the people, you don't touch them because they'll actually make noise and reverberate. I'm first going to ask the committee chairs to introduce themselves for the record, just their names and their constituency, starting with MLA Father Ray.
Good afternoon. My name is Ali Goge Father, MLA for Clayton Park West.
Good afternoon. I'm Susan Corkum-Greek, MLA for Lunenburg.
Hi there. I'm Ryan Robichaud, MLA for Clare.
Nick Hilton, Yarmouth.
Hi, Rod Wilson, Halifax, Armdale.
Lisa LaChance, Halifax, Citadel, Sable Island, and my pronouns are they, them.
Ian Rankin, Timberley Prospect, he, him.
For the purpose of Hansard, I'll also recognize, allow the Chief Counsel to introduce themselves.
David Hastings.
And the clerk.
Robin Dan.
Thank you. Okay, I'd like to welcome all the witnesses. What we'll do first is we'll go through and let you introduce your name and who you're with, and then I'll come back and then do introductions, who does opening statements. And I will start on my far left, which I believe is Abby Ferguson, how you want to be introduced also.
Yep. Abby Ferguson, she, her pronouns, Executive Director for the Halifax Sexual Health Center.
Cynthia Stockman, she, Mike.
Just a we'll figure, yeah. So I should say, if the mics are shooting straight up, point them down. So sorry.
It's okay. Cynthia Stockman, my pronouns are she, her, and I am the operational director for the Rose Clinic at Nova Scotia Health.
Rob Strang, he, him. I'm the Chief Medical Officer of Health in the Public Health Branch in Department of Health and Wellness.
Natasha Hines, I use she, her pronouns. I'm a registered nurse and board chair of Wellness Within.
Marie-France LeBlanc, she, her, and I'm the CEO of the North End Community Health Center.
Kari Ellen Graham, I use pronouns she, her. I'm a longtime community pharmacist and co-chair and founder of Access Now Nova Scotia.
Jennifer Benoit, I'm the Provincial Coordinator for the Nova Scotia Health Coalition, but I'm here today representing Access Now Nova Scotia.
Good afternoon, I'm Dr. Leisha Hawker, she, her pronouns. I work at the North End Community Health Center and the Newcomer Clinic, and I'm also a member of Access Now Nova Scotia.
Good afternoon, Stacey Burgess. I use she, her pronouns, and I'm the Executive Director of Clinical Care and Delivery at Department of Health and Wellness in the System Integration Branch.
My name's Leanne Yoshida. I'm use she, her pronouns. I'm the medical co-director at the Rose Clinic, which is the main abortion clinic at Nova Scotia Health.
Melissa Brooks, I'm an obstetrician gynecologist. I'm the co-medical director with Dr. Yoshida at the Reproductive Options and Services Clinic and an abortion provider.
And we have Dr. Kyle Wilby, virtual.
Yeah. Kyle Wilby, professor and director of the Dalhousie College of Pharmacy, Dalhousie University.
Thank you. Okay, so what I'll do is I have a list of 1, 2, 3, 4, 5 that are doing opening statements. If you want to and you're not in the list, just let me know. The mics will go on when I recognize your name. If you can wait for the mic, but don't feel bad. We talk also before the mic goes on, so it'll happen. So I'll start with Dr. Melissa Brooks.
Hi, thanks so much. So if there's one key message I hope that you take away from today's session, it's this. Enacting cost-free access to contraception is the most effective action that the government can take to significantly advance reproductive health of Nova Scotians. In Nova Scotia, lack of access to universal contraception creates a huge gap in access to contraception, especially long-acting reversible contraception, such as IUDs and subdermal contraceptive implants, which are the most reliable and cost-effective options, but cost upwards of $400. Dr. Yoshida and I see the effects of this unmet need on a daily basis in our clinical practice. As abortion providers, so many of our patients find themselves with unintended pregnancy as a consequence of not being able to afford the contraceptive options that they want or any contraception at all on a consistent basis. I have heard stories of patients that have had to choose between buying groceries and paying for birth control. That is not a choice that anyone should have to make. 1 in 3 workers in Nova Scotia do not have private prescription drug coverage. There's a misconception that family pharmacare fills this gap, and I'm here to tell you it absolutely does not. The deductibles and copays associated with this program are so high that for the average healthy person, this program is moot, and it does not improve access to contraception. At the Rose Clinic, we have established a compassionate access program for long-acting reversible contraception for patients who would otherwise not be able to afford them. And we have given out almost 500 devices since 2023. Research has proven that these patients are significantly less likely to have another unintended pregnancy and abortion, and they are so grateful to have access to the contraception that they want and need. I would be remiss to not to mention, as a gynecologist, that these drugs that we call birth control, to me, are medicines that I prescribe on a daily basis to treat conditions that only affect patients with a uterus, such as heavy menstrual bleeding and endometriosis. I often see patients unable to access these medicines and instead forego treatment altogether or choose surgical treatments, which are much more costly to the healthcare system and pose more risk to them. The best part is we can do this and save money. Research from around the globe has shown that providing barrier-free access to contraception is not only cost-effective, but provides long-term cost savings. Again, we thank you for inviting us to participate in this session. We'd be more than happy to answer any questions or to work with members of the committee or the government to improve access to reproductive care for Nova Scotians.
Thank you. Abby Ferguson.
Good afternoon. The Halifax Sexual Health Centre is an independent charitable health centre founded in 1971. The vision of HSHC is that all members of our community have full, equal, non-judgmental, and safe access to sexual, reproductive, and gender-affirming healthcare and education. I'm here today to speak to the reality that we cannot have full and equal access to care when finances impact an individual's ability to access necessary medications. HSHC has been providing low-cost and free contraceptive products to patients since the late 1980s. Our award-winning Compassionate Contraceptives program currently provides $17,800 worth of free prescription birth control to patients every year. We sell an additional volume of $3,000 to $7,000 worth of birth control products for below pharmacy prices, and then we additionally offer $3,000 worth of free medications used to treat common infections. This program is currently being funded by a 1-year project grant from the Community Foundations of NS, but is otherwise fully funded by the donations of private foundations and individual citizens. People often have assumptions regarding the kinds of patients that access our services. There's a strong narrative that we are primarily offering free contraceptives to teenagers unwilling to tell their caregivers about their sexual activity. But in reality, we are offering these products to people who come from all walks of life, including those working full-time without private insurance plans, patients on pharmacare who make just too much for a reasonable copay or deductible when you consider their other expenses in their lives, newcomers, trans folks looking to prevent menstruation, patients seeking treatment for a host of reproductive disorders, and more. In addition to speaking on contraceptives, I am able to discuss PrEP and the financial barriers to its use. PrEP management is also a service of HSHC, and we are no strangers to counseling patients who would like to be using it, except that they cannot afford the costs associated. PrEP is so expensive that it would be impossible for HSHC to step in and offer it for free to patients. If traditional private insurance plans and provincial pharmacare were enough, our Compassionate Contraceptives program would not need to exist. I implore you to listen to the diverse voices in this room and implement a no-cost, universal access to necessary sexual health medications.
Thank you. Dr. Robert Strang.
Good afternoon, and thanks for the opportunity to be here today. My colleague Stacey Burgess and I, Stacey's right behind me, will do our best to answer your questions within the scope of our areas of focus in the department. So for me, I'm the lead on questions around PrEP and STI testing. Stacey is the lead on questions around termination, reproductive care, gender-affirming care, and contraception and pharmacare. Certainly contraception and sexual health services is a very broad topic, and that does span many branches within the Department of Health and Wellness. It is also a very important part of healthcare, and it impacts all Nova Scotians. I will touch briefly upon several aspects of sexual health and the efforts we are making to support Nova Scotians. Part of our work in public health is to raise awareness about and support for access to contraception and sexual health services for all Nova Scotians. It is important because we know the broad and far-reaching impacts it has on Nova Scotians, our communities, and our healthcare system. Addressing challenges and making improvements isn't something we achieve in isolation, however. It involves our partnership with our health authorities, other health partners, community organizations, and advocates. Much good work has been done, but more needs to be done. Expanding access is one of those issues. We know that there is a desire for government to do more to provide universal access to contraception. And as Minister Thompson has stated, she wants the best deal for Nova Scotians when it comes to barrier-free access to contraception. As a result of the Nova Scotia STI Care Now program, it's an innovative program that was launched last year. People in Nova Scotia have significantly improved access to many sexual health services in person, virtually in their home, or by self-referral. It's a first-of-a-kind program in Canada that offers people ages 15 and older access to free, confidential, self-testing kits by mail and is supported by various forms of virtual care. It's an innovative program because not everyone is able to or comfortable to access traditional testing methods through Nova Scotia Health, primary care providers, or through the province's network of sexual health centers. Testing and access alone won't help people unless we can reach them where they are at. And that's where our community partners and organizations help bridge the gap between public health and people. We certainly have heard from Nova Scotians about the need to enhance gender-affirming healthcare in the province, and steps have been taken because we believe in equitable access to healthcare for all Nova Scotians. Pride Health through Nova Scotia Health is one example. They provide, among other healthcare services for the 2SL LGBTQ1A+ community, navigation support for people who want to access gender-affirming care services. Pride Health also supports people on accessing PrEP, trains healthcare providers to prescribe PrEP, and promotes education about this highly effective medication. Reproductive care is another important area within the scope of sexual health. In situations of unplanned pregnancy, Nova Scotians want options. Part of our responsibility in the healthcare system is to provide them with information so they can make informed decisions. That is why we have established a provincial self-referral line to receive information about accessing medical and procedural abortion care in the province. It is why doctors and nurse practitioners can prescribe mifepristone, a medication used for medical abortion at no cost to the patient. As I mentioned earlier in my remarks, there's a lot of good work happening to improve access to contraception and sexual health services in the province. Is there more that can be done? Absolutely. That's the answer always when it comes to healthcare. So we must continue to work together to improve programs and services based on evidence. And we must continue to engage and work with all our partners like the ones who are here today in healthcare. We are committed to continued efforts to strengthen access to contraceptions and sexual health services for Nova Scotians. So thank you, and I look forward to answering your questions today.
Thank you. Natasha Hines.
Hi, everybody. So like I said before, my name's Natasha, and I'm a registered nurse working in abortion care, but I'm joining you today as board chair of Wellness Within. Wellness Within is a volunteer-based nonprofit organization working for reproductive justice, health equity, and prison abolition. As such, we have long advocated for free universal contraception coverage here in Nova Scotia. Cost of contraception is a major factor prohibiting its use. The Contraception Abortion Research Team estimates that an individual lifetime cost for contraception may be well over $19,000. These costs disproportionately affect people with a uterus, making it a clear gender equity and human rights issue when governing one's own body comes at such a high cost. While some people's contraception may be covered by community pharmacare and private drug plans, so many people fall through the cracks of this patchwork system. High deductibles or co-pays may render coverage to be inadequate. People in low-paying, part-time, or contract jobs often do not have employer-based health plans. As many as 20% of Nova Scotians have inadequate or no prescription drug coverage. Nova Scotians are currently facing intersecting crises of gender-based violence and unaffordable living. Universal contraception is a concrete, effective, and important tool that addresses both of these issues. Nova Scotia is tied for the highest poverty rate among Canadian provinces, and Nova Scotians really cannot afford to wait any longer for this coverage. After clear success in BC and other provinces, including cost savings for our healthcare and social systems, implementing universal contraception does what the provincial government says it aims to do with the provincial budget by making life more affordable and building healthy populations. We believe that it is a common sense solution. Thank you.
Thank you. And Kari Ellen Graham.
Thank you, and good afternoon. I appreciate this opportunity to speak on behalf of Access Now Nova Scotia. Today, you have heard and will continue to hear compelling evidence on the wide-reaching benefits of no-cost contraception. 1, there is precedence. 3 provinces and 1 territory have already implemented it. 2, it's cost-effective. For every $1 invested, you can save up to $90 in social spending. BC, for example, expects to save $27 million in annual savings this year. 3, it's medically sound. Removing cost barriers leads to better health outcomes. 4, it's sustainable. A universal policy is more efficient than our current patchwork system. 5, it reflects public opinion. 85% of Atlantic Canadians support it. And number 6, it promotes equity. Contraception access is a gender equity issue and a protection against reproductive coercion. If you're unfamiliar with the evidence behind these findings, please ask. You're surrounded today by experts who can offer clear, validated data. But beyond the numbers and policy points, I want to share a story. Years ago, a young mother regularly visited our pharmacy with her baby. Her partner was abusive and pressuring her to have another child. I spoke to her about contraception, but she shook her head. She simply couldn't afford it. Months later, she came in pregnant again, tearing up behind a forced smile. Her story isn't unique, but it's one I've never forgotten. I couldn't advocate for her then, but you can now. Please use your voice to implement no-cost contraception, a compassionate, evidence-based policy that can change lives across Nova Scotia.
Okay, thank you. So the way this, for people who don't know, it's 20 minutes for each caucus. At the end of 20 minutes, and the timer will be there, I'll say I'm sorry and interrupt because we'll go to the next caucus. When we finish off, we'll do a round of probably about 8-10 minutes, and then we'll do some ending comments. So we start with the Liberal Party and, or sorry, the NDP. I do that every time, and I don't know why. Is it, okay, so MLA Lachance. Oh, just before you do, and I don't start a timer, I'll let MLA Mumberkett introduce himself. MLA Mumberkett.
Thank you, Mr. Chairman. I apologize for being a few minutes late. Derek Mumberkett, the MLA for Sydney, member 2.
MLA Lachance.
Thank you, Chair, and I will be pleased to start questioning on behalf of the official opposition. But in the meantime, it did look to me like Dr. Wilby on the screen thought perhaps they were delivering opening statements. So I wonder if we could just give that some time.
I'll ask, and if so, I'll reset the clock for you. Dr. Wilby, did you have opening comments that I did? I apologize. Dr. Wilby.
No problem. Thank you very much, and thanks for accommodating me virtually here from Toronto. My name is Kyle, and I'm a professor and the director of the Dalhousie College of Pharmacy. And I was the lead researcher for PrEP-RX, which was a foundational study in Nova Scotia that resulted in pharmacists prescribing of HIV PrEP as of July 1st, 2024, which is the first in Canada. I am an HIV PrEP user. When I relocated back to Canada in 2021 from New Zealand, I naively thought it would be the same simple process for me to access PrEP as it was in that country. There, I had a designated primary care prescriber. I was able to access all laboratory testing in the same place, and I paid a small copay of $5 for the prescription, and everyone paid that small copay of $5 for the prescription, no matter what their income was. Instead, my journey to access PrEP in Nova Scotia was very different. There are 2 major problems with accessing PrEP in Nova Scotia. First, it is well known that we are lacking primary care prescribers. I first obtained PrEP in Nova Scotia from a walk-in clinic physician, and while well-intentioned, as a pharmacist, I had to educate the prescriber about the medication and the laboratory monitoring that was required. My research team has helped to solve this issue through pharmacist prescribing. Although pharmacists are now authorized to prescribe PrEP, we are waiting for reimbursement of the service to support widespread uptake. The second and most major problem with PrEP access is cost. Nova Scotia is far behind other provinces. A patient in BC, Alberta, my home province of Saskatchewan, Manitoba, or Prince Edward Island can access PrEP at no cost. While PrEP is listed as a pharmacare benefit for specific populations in Nova Scotia, patients are required to meet large deductibles and copayments before receiving any funding. This makes the benefit largely futile, and for those that need this really important and highly effective treatment, not only to protect themselves, but to protect our overall community, both in urban and rural areas. During PrEP-RX, we offered 6 months of PrEP free for patients, and well over 50% of our patients could not afford PrEP outside of our study, meaning once the study ended, we were no longer able to support them in terms of being able to continue to take PrEP. Therefore, the current funding model is primarily benefiting people like me, wealthy people with good jobs who have third-party insurance plans. I'd like to thank the committee for making this a topic of discussion and look forward to any questions about my experience as a researcher or as a patient.
And MLA Shantz, just to let you know that I did realize Ms. LeBlanc let me know she wanted to do opening comments too. So, and by the way, I do want to thank you for that. Let me know. Ms. LeBlanc.
Thank you. Good afternoon, and thanks for the opportunity to speak here today. My colleague, Dr. Leisha Hawker, and I are pleased to be here. At the North End Community Health Centre, we understand that health is not just about what happens in a clinic. It's about access, dignity, and stability. That's why we approach care through a health and housing lens, because the conditions people live in directly impact their ability to stay healthy, make informed choices, and thrive. Sexual and reproductive health is no exception. For the communities we serve, people facing poverty, homelessness, trauma, systemic racism, access to contraception and sexual health services is not just a matter of convenience. It's about survival, autonomy, and equity. At the North End Community Health Centre, we provide trauma-informed, culturally appropriate, barrier-free care. That means meeting people where they are without judgment or cost barrier that too often push care out of reach. Offering free contraception and sexual health supports is a matter of public health, and it's smart policy. It prevents crisis pregnancies, reduces long-term health care costs, and gives people, especially women and gender-diverse individuals, real choice and control over their lives. We know that when people are housed and supported, their health outcomes improve, and when they have access to reproductive care, their futures expand. Free access to these services isn't a luxury, it's essential, and it works, and we look forward to having this discussion.
Thank you. I apologize. MLA Lachance.
Great, thank you. As mentioned, British Columbia, Manitoba, Prince Edward Island, and Yukon have all signed agreements with the federal government to deliver universal barrier-free access to birth control. And we understand that New Brunswick is moving in this direction with or without a deal. So we have waited until we don't sort of know what's happening with the federal pharmacare deal at this moment. But I hear all the compelling reasons in terms of why we need to move forward on this. For Access Now, perhaps you could start. Can you explain why it's vital that Nova Scotia follow the lead of other provinces and territories now to provide universal access to free birth control? And you talked about, how it's about more health issues than just unwanted pregnancy, and I'm wondering if you wanted to talk a bit about that as well.
Ms. Graham.
Thank you for that question. Very important that Nova Scotia gets on the bandwagon now. We are lagging behind a little bit from the other provinces and territories for sure. Now is our chance. There's money on the table from the federal government. We've been advocating for this without federal money, and certainly BC did it on their own, and we could as a province, but we have this money on the table right now. We don't know how long it's going to be on the table, so it would be to our best advantage to use that federal money as money right now. So that's why we should do it now for an economic standpoint for sure. But of course, as we've heard, there are multiple other reasons why, particularly equity. As we know, it's a problem right here, right now in Nova Scotia, and this is one way to take a tangible step towards solving health gender equity issues. But as you said, not just for birth control. Some of our colleagues up here have mentioned other indications for heavy menstruation, endometriosis, transgender care, even hormone replacement therapy. There's all kinds of other indications and reasons why we should be approving contraception, not just for birth control.
Thank you. MLA Lachance.
And I'm wondering, Ms. LeBlanc or perhaps Dr. Hawker, you were talking a bit about the reality of folks who come to see you at the North End Community Health Clinic. And so, you know, I guess if you could walk us through a bit more, like how many of your clients would you say can't access birth control but would like to for whatever health reason? If you could walk us through, you know, you talked about some of the barriers, but just what that really looks like sort of for folks on a day-to-day basis.
Dr. Hawken.
Thanks for that question. So at the North End Community Health Center, I provide gender-affirming care and well woman care, and I also treat a lot of patients with opioid use disorder and other concurrent substance use disorders. Many of our patients are insecurely housed. Many of my patients are fleeing intimate partner violence, which, as you know, is an epidemic in Nova Scotia. Just yesterday, I had a patient who was afraid to go to the pharmacy because of her ex assaulted her recently. And so it's really important that we have this, because right now I have patients who are on income assistance pharmacare, and that's probably like the easiest route for my patients to get access. But there's many who are more working poor, so they're working at Wendy's or the dollar store, for example, jobs that are sometimes cash and under the table. And many of my patients can't afford it outright when they pay out of pocket. Then there's the family pharmacare, which many of my patients, as Dr. Brooks, I think it was mentioned, the co-pays and the deductibles are just outrageously high. One of my patients at the newcomer clinic today, I thought I was going to be late because I was on hold with pharmacare. He was confused because he said, I thought I had pharmacare, but I'm still paying for my meds. So while this wasn't contraception, I figured out from talking to the pharmacare that his max copay is $270, and while he may have paid down his deductible, he's still only $22 into that $270 copay. So most likely by the time he gets that paid off, it'll be starting all over again in April. Every year in April, I have many patients relapse because their pharmacare doesn't get renewed because they're insecurely housed. The mailing for the renewal goes to the wrong address, and it usually takes a couple months to get them back on track. And when my patients are in recovery for addictions, the last thing they need when they don't have a house and when they're trying to recover from substance use disorder is to have an unwanted pregnancy.
Emily Lachance.
I wanted to ask a bit about, you know, some of the places where we have seen the impact of, you know, barrier-free access. So the folks from the Rose Clinic spoke about the ability, once you were able to provide IUDs, that, you know, in a barrier-free way, that the rates of insertions increased radically. And can you tell us a bit about you know, what you see, like what were the advantages you saw of that, and if you're still offering access to IUDs?
Dr. Yoshida.
Thanks for that question. And so, to be clear, we are able to offer barrier-free, long-acting reversible contraceptions like IUDs and contraceptive implant purely from donations from the public. So we have had times when our donations run out and we're no longer able to provide the devices to patients who need it. And as Dr. Hawker said, a lot of our patients are working poor. They may, even the ones who are lucky enough to have a third-party insurance, sometimes their copay is 50%, and these devices are over $400. So to have $200 ready to pay as their copay is sometimes very difficult. with all their other financial constraints, and those are the patients with insurance. So we have many patients who just can't afford it. So when we are just able to, during our screening and asking them what their choices are, we often hear people who knew about IUDs and were interested and were waiting to save money or to get their insurance to kick in, and while they were waiting, they had an unplanned pregnancy. So we hear on a daily basis, we hear this. So it's just so clear to us the need for barrier-free access, because the cost of performing an abortion at our clinic is much higher than a device that can provide excellent contraception for 8 years. So the economics and the finances of it is so clear. But beyond that, just the gratitude of the patients, all of us who work at the clinic just get such sincere thanks from our patients when we tell them that we can actually provide them with their preferred method of birth control at no cost. And I think that, to me, on a personal level as an abortion provider, is the most powerful part of what we're able to do.
Emily Lachance.
And so, you talked about the economics of being able to provide this. Dr. Strang, we understand from a Department of Health and Wellness, FOIPOP, that the cost of delivering free access to birth control in Nova Scotia is estimated to be $8.5 million per year. Do you think that cost would be offset by other public health savings?
Dr. Strang.
So we'd have to look into that and do the health economics around that. I can't answer that off the top of my head.
Emily Lachance.
At this point, I'm going to pass things over to MLA Wilson.
Emily Wilson.
Good morning. Thank you, everyone. Actually, good afternoon. Thank you, everyone, for joining us. I know the work you do, and I also know your impact, so I'm grateful that you're able to speak to your experience today. My questions are related to PrEP. I guess the first question would be for Dr. Wilby. You mentioned previously in other conversations that estimated 8% of eligible PrEP users in Nova Scotia only an estimated 8% of PrEP eligible users in Nova Scotia take the medications. You explained some of the barriers. Can you explain who this population might be and what other reasons are that 8% are not taking it or accessing it?
Dr. Wilby.
Sure, and the statistic was from a few years ago where only 8% of people were taking it. So there's a major gap in people who are eligible for PrEP that aren't able to take it for the reasons that I described. One was prescribers, two is really the funding model. And these people are from many different populations. It is important to note that HIV PrEP users are not a major population. So when you're thinking of doing widespread funding or changing the funding model, the cost associated of that will not be that significant. The people that are not taking PrEP that would benefit are students. Again, I'm the director of the College of Pharmacy, and I have students in my program that aren't able to access PrEP. It's gay, bisexual men who have sex with men, transgender women, a population who really does not have a major voice in healthcare and also suffers from other aspects of health inequalities and inequities. People who inject drugs is another major population. We've done the interesting thing too about PrEP is that it's not just the medication itself, but it comes with a program of STI testing and treatment. And so we completed another study called SwabRx, where we found large pockets of chlamydia and gonorrhea inside the community that would have been actually discovered if we would have those patients on PrEP, but they weren't taking PrEP at that time. So it's people all throughout the province, all throughout all corners of the province, but don't have a loud voice, as again, there is not all that many people out there that would qualify. However, those that would qualify would greatly benefit, and those that would qualify are currently not taking the medication.
Emily Wilson.
Thank you. Could you tell me what the out-of-cost pocket is for someone who's not covered by pharmacare for PrEP in Nova Scotia?
Dr. Wilby?
Yep, so an out-of-cost pocket for 3 months supply is about $700. So again, unaffordable for many patients who are students or who are not in well-paying jobs or do not have private insurance. And it's important to note that if you break that down per month, it's about $200 to $250 per month. And that translates into a cost of treating HIV, which can be between $1,500 to $2,000 or more per month. And so by having people on PrEP, we are actually creating that a good ratio in terms of preventing an HIV infection that would then cost the healthcare system even more money.
Dr. Wilson.
Question for Dr. Strang. In 2018, PrEP was introduced in Nova Scotia under the pharmacare or means tests. Can you tell me what's happened to the HIV rates in Nova Scotia, the incidence rate since 2021?
Dr. Strang.
Sure, thanks for that question, and I have the data in front of me. So from certainly our overall incidence, the new cases of HIV have increased from 2021 to the latest data we have in 2024. So in 2020, we were about 1.5 new cases of HIV for 100,000 population, and now we're at roughly 3 cases per 100,000 population.
MLA Wilson.
And can you tell me, either yourself or Dr. Wilby, what's the single cost of HIV how much does a single case of HIV cost the public health care system over a person's lifetime?
Dr. Strang?
You have to do the math, but when we looked at this, and I looked this up last night, in 2019, when we did health economics around this, for somebody who was uncomplicated or HIV, it was roughly $9,600 a year for them for the cost of their treatment for their HIV.
MLA Wilson.
So according to my research, Dr. Strang, the evidence is overwhelming support in the literature and in other jurisdictions that universal access to PrEP, as in BC, significantly reduces HIV incident rates in the population. Is that true?
Dr. Strang?
Certainly my understanding from the evidence that increasing access to PrEP is one of a number of factors that are important in reducing HIV rates as low as possible.
MLA Wilson.
Have you done any estimates on how much it would cost to deliver PrEP as a universal access program in Nova Scotia?
Dr. Strang?
In public health, we have not done that. We partnered with our pharmacare program. I don't have those numbers in front of me, given based on today's costs.
MLA Wilson.
On the face of it, it appears both evidence and common sense that it would be cost effective. So based on your knowledge and experience in the Department of Health, do you know if there's been any recent proposals put forward to the Department of Health for full funding of universal access to PrEP?
Dr. Strang?
Yeah, I am aware that pre-COVID, there was at least one time where we did develop a proposal for universal access to PrEP through part of the, the annual business planning cycle in the department.
MLA Wilson.
I think those were the bulk of the questions I have. Thank you.
MLA LaChance.
And actually, speaking of sort of the annual budgeting and planning process that happens in government, we also have, received documents that show the Department of Health and Wellness had a plan to make birth control free for Nova Scotians under the age of 25, and that this was being developed for the purpose of being included in the provincial budget, developed in the fall prior to the election being called. And I'm wondering if any of the witnesses here today were consulted on that plan or were aware of it.
Who do you want me to ask that to? That's kind of a broad. MLA LaChance.
Well, I guess I was looking for volunteers, and in broadly, so I see a hand raised over there by Ms. Graham.
Ms. Graham, please.
So I wasn't consulted, and our pharmacy group or association wasn't consulted, but I would like to talk a little bit about the economics that you brought up with Dr. Strang earlier. And I just wanted to highlight that there are a ton of economic data out there already that we can easily extrapolate to Nova Scotia. And BC has been really good at being transparent with their numbers. Again, for every dollar spent, we can expect $90 in public expenditure savings, and that's through social supports that moms who have unwanted pregnancies might not have to rely on, through community supports, the cost of raising a baby, all of those supports and expenditures would decrease, obviously, if we had funded birth control in place. But we know that provinces are receiving money through this federal grant in the tens of millions in BC. PEI just signed on for 30 million, which is about 7 million per year. We can extrapolate maybe 15 per year, 15 million in Nova Scotia, but we know that we're going to save in another silo of money, triple or quadruple that amount when it comes to social expenditure savings. And again, I want to highlight our very high health budget here in Nova Scotia and our pharmacare budget. We are simply looking for one line, maybe 1% of our budget up front, but again, we know we're going to save quadruple or triple that in the long term. So very good question that I wanted to address. Thank you.
MLA Lachance?
And I mean, that is very helpful, and that's, I mean, the BC numbers are helpful real-time data for sure. Thinking about this proposal that we understand was alive in the provincial government last fall, as a parent of young adults, I can tell you that I have lots of firsthand experience with their friends not being able to access adequate contraception. Because I'm willing to talk about it, we get to talk about it a lot at home, so I can understand a little bit why the proposed program would have capped that at the age of 25. But I guess, and maybe I'll start with Ms. Graham and come back in the second round of questioning. But does it make sense to you? I mean, is there a need to be hesitant and to just focus on the under 25s, or what would you have to say to a proposal like that?
Ms. Graham?
Of course not. No, it just creates more inequities in our healthcare. It should be wide open. There should be no age. It could be 10-year-olds, 11-year-olds, 12-year-olds, up to 60, 70-year-olds who require this medication. Enough with inequalities and caps and restrictive formularies and restrictive money. Make it universal. It's a no-brainer. It makes sense. It's easy to do. We're ready to do it. And BC has already shown us that any restrictions that they have put on their birth control, they had a strict formulary of what they would approve out west, and they've since reversed that. But their advice to our province is to go wide open, all ages, all forms of birth control, no copays, no deductibles, make it universal, do it right the first way.
MLA Lachance with 33 seconds.
And with those 30 seconds, is there any other witness who wants to pop in for a couple of seconds around that question?
Ms. Hines, and then...
Hi, I did want to speak to the age gap of the proposed coverage for under 25-year-olds. I will say at the in abortion care, we do see that many of the unplanned pregnancies tend not to be in youth. They're usually between, I would say, in their 20s, 30s, even up to 40s. So we do see that this isn't, unplanned pregnancy isn't necessarily an issue that only impacts youth.
Order. Perfect timing. So the next 20 will be for the Liberal Caucus. MLA Mombercat.
Thank you, Mr. Chair, and I want to thank everyone for coming to present to us today and to committee. I'm going to start my questions off with Rose Clinic. And last year we heard that the Rose Clinic was running low on donated funds to provide free contraception. For many Nova Scotians who can't afford IUDs and don't qualify for public pharmacare, this program has been one of the only ways to access care. It raises an important question. Should access to essential reproductive health care really depend on donations? So my first question to Ms. Stockman from the Rose Clinic, what is the current situation at the clinic? Are donated contraceptive devices still being used, and has new funding or coverage streams been secured?
Dr. Brooks?
Oh, sorry. I'm sorry.
So yeah, most of our funding has come from donations through the foundation, and they've kind of fluctuated with time, and sometimes when things happen in the US, it kind of gives us a little boost in how much people donate to us, which is great. But you're right, we shouldn't have to depend on donations in order to provide healthcare, good healthcare for our patients. We have been working with DHW to try to secure some more consistent funding, and that's kind of in the works, and we're working on more consistent funding for that program. But I think if we were able to get universal access to contraception for everyone in the province, then our program wouldn't even be necessary, which would be the perfect situation.
Emily Momberkat.
Yeah, thank you, and you're absolutely right. We're all, as elected representatives on this side, we've also advocated that as they negotiate a new healthcare agreement with Ottawa, that this is part of it. This is something we plan on talking to our Liberal colleagues about too as well at the federal level. And you make an interesting point, and maybe through you, Mr. Chair, if you could elaborate, that relationship with the Department of Health. Have you seen additional funding come? Has anyone reached out in regards, we're hearing it, that donations, you shouldn't have to rely on donations. Donations come in waves. And you mentioned in your comments about the Department of Health and potential funding with them. So could you elaborate on that a bit? Are you having those conversations with them now? Do you see any, until there's a new deal negotiated, which we're all pushing for, have you received any additional funding, knowing full well that, the donation system is important? Thankfully, we have wonderful organizations that will donate, but are you receiving any additional funding or hopeful to receive any additional funding from the Department of Health and Wellness until that deal is signed?
Dr. Brooks or?
I think Stacey Burgess.
Oh, Mrs. Burgess.
Hi, thank you for the question. And so my team and the Rose Clinic have been working very collaborative in the last year and a half. And so we have gave a one-time grant, and we continue to work with the team to think about long-term funding, but as well, we have a very open relationship that if the funding is starting to deteriorate, there is a call to us to have more of the discussion of what that'll look like, why we continue to wait on what the future will look like around universal contraceptives.
Emily Momberkat.
Thank you, Mr. Chair, and I appreciate the answer, and that's really kind of the key. We see that with organizations really across the province that are supporting our vulnerable population in many ways, that the ability to be able to pick up the phone if resources are starting to decrease is critical. And hopefully, as I've said, that and we're going to continue to push that a deal is signed. Sticking on the same topic with the Rose Clinic, how many patients, and you've said this, you can elaborate on, how many patients typically are accessing the service, and have any been turned away or delayed in receiving care due to limited funds?
Dr. Brooks?
In terms of how many patients we provide abortions to, it's usually like 5 or 6 per day, Monday to Friday. And thus far, since we've started the program, I don't think we've turned away anybody that's required long-acting reversible contraception. We've been able to keep funds through our donations to supply those. So we have not had to turn anybody away, thank goodness.
Okay. Emily Momberkat.
Thank you, Mr. Chair, and I appreciate the information and the answers to the questions. My next question, again around the Rose Clinic, with each device costing an average of $400, what kind of short-term funding solutions could you use now to close any gaps? Are you seeing any gaps now? And is there any other solutions that government could be providing to help provide that support?
Dr. Brooks?
Yeah, I mean, like Dr. Yoshida said, we're only able to provide long-acting reversible contraception, so IUDs and contraceptive implants, which not everyone actually wants, or there are some reasons that people can't use those devices. So for people who want to use things like birth control pills or injections, we can't help with funding for that. We could cross-reference with the Sexual Health Nova Scotia, and sometimes they can be helpful for our patients, but really, as I think everyone's talked about, those working poor patients, so the people who don't have community services, pharmacare, don't have private drug insurance, or their drug insurance doesn't really provide good coverage, there really is not a lot to do for those patients. Like, those are the people who do get lost in our current system. From what we see, I think from what they see, what they would see at the North End Clinic, what I see as a gynecologist, those people who really can't afford prescribed medications, there is not a safety net for them currently.
Emily Momberkat. Ms. Ferguson.
Thank you. I'd love to jump in there. So yeah, Halifax Sexual Health provides compassionate contraceptives. So we're around like that $17,000 a year worth. And I want to highlight the fact that your access to free contraceptives are coming in these very siloed places, right? So if you're accessing an abortion, that's where you can access your long-acting form contraceptives, or if you come through Halifax Sexual Health. But if you don't have those options, or if you have a family care provider who would love to offer you a contraceptive option, you are then forced to then replicate your appointment and come to Halifax Sexual Health so that we can see you and prescribe that medication, because we are not a pharmacy. So we're not only seeing restrictions in terms of the cost, but then we're also seeing restrictions in where you're required to get an appointment. I'm not sure if folks are familiar, but getting an appointment with Halifax Sexual Health is a bit of a battle royale. We can serve generally anywhere between 11 to 12,000 patients every single year, and we receive thousands and thousands and thousands more calls than that. So then you are then duplicating that appointment. Even if you had a primary care provider, we are then just doing that same consultation so that we can write you that script, and that is a huge waste of healthcare resources.
Emily Momberkett.
That's a great point. And it kind of leads into my next question. And I can completely appreciate if the information isn't available, and I think everybody would have to go back and kind of track it. But it leads to the question you make the point around that you support 11, 12,000 patients a year, but you're getting thousands of calls more, and it really kind of begs the important question for me is, and I come from Cape Breton, so so I come from an area that I know there's some great organizations on the ground that are helping support folks every day. But how, in your opinion, and this could really go out to anyone, and if there's data around it, how many people are being denied and that could be because of healthcare coverage or because of capacity to support? Is there an average out there? Like statistics have been used today, like around percentage of people that have pharmacare or have a health plan versus people who do not. But in your opinion, how many Nova Scotians who are looking to access this support, how many are being denied?
To who, Emily Momberkett? Emily Momberkett? Oh, Ms.
It could be to Ms. Ferguson, please. And in the back too as well.
I would say that it's like deeply challenging to put numbers on a void, right? So like what we're talking about is addressing a gap, and how do you count the folks that are living in that gap? Like I can tell you about the thousands of calls we get every single year from folks looking to get appointments, but we're full. But that doesn't speak to the folks who never got through on the phone, who thought about it, have heard from friends about how challenging it is. Or if you're talking about something like rural access, if you are someone seeking a birth control prescription and you're calling from Cape Breton, and we can do that virtually, I can't mail you that free contraceptive. And I can't send a fancy voucher to your pharmacy that says trade this in for free contraceptive. So that doesn't solve the problem of rural access as well. So I know numbers are very desirable, but I think it's deeply challenging to, when this is a void that we're talking about, to like put a number on what that is. At Halifax Sexual Health, we have not turned anybody away for free contraceptives since 2017. We had a huge budget, like operational budget during that time, in which we were cutting literally everything to stay alive. And one of those things, the first things to go, was our compassionate contraceptive program, because that is funded by individual donations. Individual donations are something that I can use to pay staff, right? So without like program funding to sustain it, it is something that will go away. If something happened to our private donations and that $17,000 is not available, again, I would have to scrape that out of how I turn the lights on and pay my staff and buy speculums.
Emily Momberkett.
Yeah, thank you. And that's, I guess that's another part of the fact of, you raised, I'm sorry. Did you want to, Dr. Brooks, did you want to respond to my last question?
Okay, so yeah. Dr. Brooks and Emily Momberkett, Dr. Brooks and then Mrs. Graham? Okay, Dr. Brooks.
I was just going to add, again, it's hard to put numbers on it, but when you look at Canada in general, our rate of unintended pregnancy is about 40%. So 40% of pregnant people become pregnant not meaning to. And when you compare us to other high resource countries, we're not doing great in terms of the number of people who end up having unplanned pregnancies every year. So we certainly could improve vastly. And really, when you compare us to other countries like the UK, where people have more free access to contraceptives, those are the places where they have more reasonable rates of unplanned pregnancies. So if you look, we don't have data specifically for Nova Scotia, but Canada in general has a fairly high rate of unplanned pregnancies if you compare it to other high resource countries.
Ms. Graham.
Exactly what I wanted to highlight, Dr. Brooks. At least 40 to 50% of pregnancies are unplanned, and we know that there's about 10,000 babies born in Nova Scotia a year. So maybe about 5,000 babies are born as unwanted pregnancies, if you want to extrapolate that data. And I also just want to highlight that everyone up here is so keen and amazing, and the Rose Clinic, of course, they do bend over backwards, and the Halifax Sexual Health Centre, trying to help the patients that walk through their door. And because they're so amazing, they do an excellent job. It's all of the patients who don't walk through their door that aren't getting served. And again, highlighting what you've already mentioned, MLA, Mumbercut, all the calls that you're getting, but even people who don't have the resources to make those phone calls or to get themselves to the clinic, and rural Cape Breton and rural mainland Nova Scotia, all of those patients who don't have the Red Door, who don't have the Halifax Sexual Health Centre, who don't have the Rose Clinic just to walk up the block. So, amazing job on the efforts of these people, on the patients that they see, but there's so many patients that they don't see who aren't getting the services that they need.
Emily Mumbercut.
Yeah, and I really appreciate the responses to the questions, and you're absolutely right. I see it on the ground in Cape Breton, two amazing organizations really stepping up with limited resources, relying on community advocates and organizations that really step up to help support these organizations that are helping folks each and every day. And I guess one question is, and we talk about unplanned pregnancies and the percentages around unplanned pregnancies. Are you seeing the provinces that have implemented, whether they've signed a deal or they've made this universal access for everyone? Do you have any information on the percentages in those provinces? Like, have they declined when it comes to that rate of the unplanned pregnancies?
Emily Mumbercut, I believe Ms. Hines has a. Ms. Hines.
I don't have numbers on the unplanned pregnancy rates, but I do have a few numbers from BC about the success of implementing their program. So the program was implemented in BC independently from the federal government in April 2023. And from April 2023 to December 2024, 306,000 people in BC received free contraception. And the contraception abortion research team found that as of June 2024, the number of people using any form of prescription contraception increased by 10%. So I know that doesn't directly answer your question to the rate of unplanned pregnancies, but it certainly does. It goes a long way to show the need that this program has filled and the uptake in using contraception to prevent pregnancy.
Emily Mumbercut.
Again, thank you for that. And you're right. Like, just your percentages around more people who have access to it and are using contraceptives obviously is going to support folks in the community. I guess one question I have, and because we talk about Nova Scotia signing a new deal with Ottawa, that this be part of it. And I guess this is an open-ended question too as well, and I think my colleague kind of brought it up too as well, and really kind of the key to this for government is going to be consultation with experts like yourselves. So as Nova Scotia's been negotiating this deal with Ottawa, which we're hopeful will come to a conclusion that is positive, have you been have your organizations been consulted at any point throughout the negotiation?
Anyone? Okay, so Ms. Graham, and then Dr. Yoshida.
Yeah. In direct consultations, particularly with the New Brunswick government, who are trying to push the the funding with the federal program through, and have had some resistance and are considering maybe doing their own internal thing. And I want to say that hesitancy from New Brunswick has been surrounding the diabetes part of the funding, not the birth control part of the funding or the contraception. So that's their bit of a hesitancy there. But yeah, they have been reaching out indirectly through some leads there. Of course, Mark Holland was making the rounds last year and was reaching out for indirect comments in what's going on here in Nova Scotia. And I know the helm has been passed to Camel Cara. And again, they have been reaching out indirectly for what's going on in the ground Nova Scotia and what we can extrapolate from the Western provinces.
Dr. Yoshida.
I was just going to say that we have not been consulted.
Ms. Ferguson.
We have also not been consulted.
Okay. Ms. Hines.
I want to say, since Wellness Within is part of the Access Now Nova Scotia coalition, Access Now has been trying to get kind of FaceTime with the provincial government to discuss this issue for a long time, and we have yet to be successful until today. This is the most meaningful kind of dialogue we've had, but there hasn't been any consultation.
Okay. Ms. LeBlanc.
I would say that it's also part of our conversations every time that we're having government consultations is to advocate for this, but at this point we haven't had any success.
Okay. Ms. Benoit.
Yes, so I can affirm what others are saying. The Nova Scotia Health Coalition has not been consulted on this as well, and it's not from lack of trying. We've reached out many times. Thank you.
MLA Mombercat with 2 minutes.
Thank you. And I find that very alarming, Mr. Chair, that we're about to sign a multi-year historic agreement negotiating with our federal government. And this is the importance of these committees, that's for sure, and it's shown up again today. And it's a theme consistent with many of these committees that we're on, is that we have wonderful advocates and experts coming into this committee who are pressing an important issue around supporting Nova Scotians, and no consultation has been done by the government. That is really, there's many words I can use for that. That's discouraging. That is absolutely wrong. And I hope that decision makers are watching this. You know, for you to come here to this committee today, it's an honor for us to sit here as MLAs in this community. And I learn a lot. I learned a lot by just listening. I've been around for a couple of years now as an MLA, but this is something that, you know, is evolving in our communities. You know, I'm learning about donations covering really the supports that many Nova Scotians are accessing. And I can't thank you enough, really, for the work that you're doing on behalf of families really right across this province. So I know I'm kind of going on, I don't have a question, I'll have another round, but we just went around this room in the committee and everybody said they were consulted and we're negotiating a new deal with the federal government. That's, to me, that's appalling. And I'll stop now, pass the rest of my time on, but I just want to reiterate, I really appreciate you answering my questions. We'll have some more in the next round. I learned really a lot, and I really just can't thank you enough for the work that you do to support people across the province.
Thank you. So the next 20 minutes will be for the PC Caucus. MLA Corkum Greek.
Thank you, Chair. And I would genuinely like to thank all of you. One of the difficulties of these committees, particularly when we have such a robust and large group of clearly passionate people about what you are doing, for which our province is really lucky. We're really grateful. But I think I could sit down with any of you for 2 hours, and I have been making more notes, and I have colleagues who also want to ask questions. I sit here as a Nova Scotian, as a woman, completely aligned with the case that you've made. We want to empower women. We want to empower gender diverse individuals, families, to be able to make choices about their lives, including when or perhaps if to have children, when they might wish to start a family. And we know that when unintended pregnancies happen, that it can be very disruptive and it can disrupt their education. I realize right now I'm preaching to the choir of how disruptive, if not destructive, in terms of tying them perhaps to partners who are abusive and so forth. So absolutely hearing your arguments. There are decision makers, all of us arguably in this room. But I would like to take a moment to focus on this pharmacare situation, the offer of the federal government. At the end of the previous government's term in 2021, they signed a child care deal that, in our view, was a bit short-sighted. Among other things, it excluded private operators in a province where private childcare was very important to the mix of being able to provide childcare. And our government has been working steadily since that time to address that gap, and yet we face a federal government that to this point has been rather inflexible, and we hope we continue to work to get to a better place. This is another situation where the federal government has put forward the offering of funding, and we are very interested. We don't want to leave money on the table, but it does highlight that the devil truly is in the details. So my question is to Dr. Strang, possibly to others here on behalf of Department of Health and Wellness, if you can explain a bit of why there's value in not rushing into a deal and perhaps some of the considerations on the table.
Dr. Strang?
I'm not involved in this in any way, shape, or form. We're going to pass that to my colleague, Stacey Burgess.
Ms. Burgess.
Thank you. And first and foremost, I want to say that I hear you. Definitely hear all of your comments today. So thank you for that. And I will be taking it back to the department. As I said at the beginning, I am with system integration, so not directly in the pharmacy department. But what I can tell you is that we, as Dr. Strang mentioned in his opening comments, the minister is looking to get the best deal for Nova Scotians. And so we are interested in going back to the table. We're waiting for that invite and to really look at ensuring that what we sign or do is both financially responsible for Nova Scotia. It doesn't change any of our current programs that we have in place, and that we have long-term funding for it.
Emily Corcoran-Greek.
So I think what I'm taking from your answer, and I do understand sort of the arm's length of per the negotiations, but there is a sustainability issue that is amongst some of the considerations. You know, there were references earlier, we are living in extraordinary times. I believe the reference was made to donations to the Rose Clinics programs, perhaps being positively influenced by what we're watching in the United States. And as a woman of a certain age, it seems impossible that we are in a world where Roe versus Wade has been overturned. I'm hoping that the representatives from the Rose Clinic could give me a little insight in terms of what access to abortion looks like in Nova Scotia and the improvements that have been made in recent years to access.
Dr. Yoshida?
So in terms of access to abortion, it really changed a lot in 2018 when we were able to remove a significant barrier, which was that patients needed to be referred from a physician to access an abortion at our clinic, and we were able to remove that barrier in 2018. And we have a toll-free phone number and online form where patients who are facing an unplanned pregnancy, whether or not they've even decided if they want an abortion, can just contact our clinic directly. And in 2018, that's when the medical abortion option, the medical abortion pill, also came into Canada. And so it was a perfect time to provide easy access to any abortion that the patient preferred, whether a procedure or the pill. So that has changed significantly, and since then, we've also been able to expand the access to prescribers, nurse practitioners, family doctors, and gynecologists throughout the province who can prescribe mifepristone or mifegameza, which is the trade name for the medical abortion pill. So I think we were quite proud of this. So the changes since 2018 have been significant, and we hear that from patients all the time. Patients who had tried to access abortion care before 2018 and after 2018, they've noticed the difference and they've given us the feedback. So we're very proud of that. But again, to speak to this issue here, of course, we're very proud to be Canadian and have no laws about abortion, and we're very proud to work at the Rose Clinic, which we think provide excellent care. But as we say to every patient, we also would prefer not to see them again. So as much as we get such sincere thanks for the care that we provide, we all know, all of us working there and all the patients we see, that an unplanned pregnancy, even if they are able to access excellent care, is still disruptive, as you had mentioned, to their life. And for the patients that we see are choosing to have an abortion, patients that Dr. Brooks would see in the IWK are choosing to continue the pregnancy. So an unplanned pregnancy can become a wanted pregnancy, but it still was initially unplanned. And I think we don't want patients to have to be in that situation when such effective contraception is there. It's right there. And the only barrier is a few $100s per device. Again, it's just so obvious. And I always say it would be lovely if we could close the doors of the Rose Clinic because there's no unplanned pregnancies. But we all know that to get to that stage is impossible. And even these excellent methods of birth control are not 100%. And we've all, at the Rose Clinic, we've seen every method of birth control, even surgical methods, fail. So that goes without saying, but why not at least give people the option to have access to the best that has been invented?
Emily Corcoran-Greek, Ms. Hines raised her hand. Do you want her? Ms. Hines.
Hi, sorry. I just wanted to add to what Dr. Yoshida was saying, and in providing excellent abortion care is extremely important. It should be noted, too, that abortion is publicly funded by our healthcare systems, and so is medication abortion. So mifegameza is publicly funded and free for anybody with a provincial health card. So modeling that in the prevention of unplanned pregnancies as well only makes good sense. I would also say, kind of to your comments previously about wanting to navigate a fair deal, we should lean on our other provinces who have done this before us as well and have had success. We aren't the first province that would be attempting to do this, so I think we do have good resources from other provinces across the country as well.
Emily Corbin. So I always check with the person asking the question. Emily Corcoran-Greek, Ms. Graham has a comment. So, Ms. Graham.
First of all, I just want to say thank you. We have been advocating from Access Now Nova Scotia for 2 years. We have sent multiple letters to the government, Premier Houston, our Minister of Health, Kathleen Coleman. We've had very little response. You are the first person to voice your support for this. So thank you for the government and representing them so well here today. But I also want to circle back to any hesitancy that the government would have to signing this federal bill. And I know it just became, proclaimed about 9 months ago or 10 months ago. But really, we've been looking at this issue here in Nova Scotia when it was first introduced in our House of Legislature as Bill 80 almost 7 years ago by the NDP. And it's been out for decades before that looking at this. So we have a ton of data. We have a ton of research, mostly spearheaded by the NDP, backed at some points by the Liberals. We've been looking at this not for 10 months, but for years and decades. Other countries have been doing this for decades. Other provinces have been doing this for a year or more or months. And I know we want the best deal for Nova Scotia, but for goodness sakes, we've been looking at it and we've got the data, and it's a no-brainer. Also want to say that BC were funding this interprovincially, and then they signed on to the federal deal. It was an easy transfer for them. We can sign on to this federal deal. If we don't like the strings attached, we can move it to an interprovincial funding thing. Right now, it makes sense, and of course, we sign on to deals in lots of different things, and you brought up childcare, where in the long term, we find out, okay, maybe the specifics weren't exactly what we wanted, but we can address that at a different time. Right now, it is working well for other provinces and territories, and again, I think Nova Scotia is clearly lagging behind.
Emily, Dr. Brooks. Okay. Emily Corcoran-Greek.
Thank you. And again, this is one of the challenges of having so many, not just passionate, but deeply knowledgeable front lines of these issues. And so it is not easy to say. We see more hands, but I'm going to move on with one more question myself, or my colleagues are going to give me the heave-ho. A lot of us represent rural areas, as well as marginalized communities where access to services can have challenges. Emily Mombercat referenced, on Cape Breton Island. I'm down on the South Shore, and while I deeply appreciate services like those provided through South Shore Sexual Health, my long ago colleague Julie, shout out to Julie, who I'm sure is not watching Ledge TV this afternoon, or the Second Story Women's Center, but I wanted to ask our partners here about the role in making sexual health services more accessible. So beyond the very present issue of the contraception, either drug or methodology, the advice and support, and if there are those who can speak to that matter.
Dr. Brooks.
That actually speaks to what I was going to comment about. And Dr. Yoshida did talk about the advances we've made in abortion care, but we still have issues with access, one of which is access to procedural abortion in Nova Scotia. So currently we provide it in Halifax, there are gynecologists who provide it in Kentville, and that is it for the province. If you live on the South Shore, if you live in Cape Breton, you have to drive to Halifax if you want a procedural abortion. There are hospitals in this province with gynecologists who want to do abortion, and they are prevented by the hospital from providing that abortion. So that is certainly something that we can do to improve access to abortion in this province. The other thing is gestational age. Currently at our clinic, we provide access to 15 weeks and 6 days. We'd love to advance that. We were currently declined an increase in our funding in order to support that. But increasing access, we're probably one of the lowest in the Atlantic provinces right now for how high we go for abortion. And we could definitely improve that with a bit of additional funding to our clinic.
Emily Corcoran-Greek.
Thank you. I will pass the remaining time over to Emily Fadari.
Emily Fadari.
Good afternoon, everyone. I think I'll echo the thoughts of everyone. It's great having everyone here today. I think it's a very important conversation. My first child is a girl, so I'm very concerned about female well-being, and I believe in the power of choice because that determines, I always say that a decision determines your destiny, so I think it's important that people have the opportunity to make those decisions. I know we've spoken a lot about finances today, and I see we've talked about all the type of barriers, but I'm just wondering, to any witness who wants to talk about, apart from finance, apart from capacity, what other barriers do we have we noticed, and what are we doing about those barriers? So, for example, I know there's a bit of culture. I know there's also a bit of religion. I also want to believe that there's also an issue regarding systemic. I know, for example, while I was at Dalhousie, we did a study regarding lack of people from historical Black and Black population with trust. So I'm just wondering, what other issues have you seen that are barriers, and what are we doing about those barriers? Because I know that it's not just about capacity, it's not also just about money. There are a lot of some of these others, and maybe there are more that I didn't echo that you've observed, and this is open to anyone who is willing to talk about it, because I realize there's a lot of experts here, so I'll throw that too.
Okay, Ms. Hines, then Dr. Brooks, and then who's back there? Oh, Dr. Hawker. Ms. Hines.
Hi. So you're right. There are a lot of issues that impact people's access to sexual and reproductive health. Some of them being, culture, religion. Another big one is education. So comprehensive sexual education in schools and in communities. And certain people from marginalized populations facing barriers like poverty, being unhoused and things like that. I will bring it back to a lot of these issues can be remedied or at least supported by removing cost as a barrier. So people who do face intersecting issues like, stigma, systemic racism, poverty, all of these things, when you remove at least one barrier, which we're in a position to do, it helps greatly with those issues. And I will say that a lot of the witnesses here today, we're all part of the Access Now Nova Scotia committee or coalition. So if you ever only had time or wanted to meet with one of us, we do all communicate with one another. So we'd be happy to have one representative meet with you instead of all of us.
Dr. Brooks.
This is very specific, but the current immigrant population in Nova Scotia, a lot of them prefer copper IUDs as contraception. And because the copper IUD is not a drug, it's actually not covered by any kind of pharmacare. So for patients who choose copper IUD, which is more preferred amongst immigrant population, they don't get coverage for that.
Dr. Hawker.
Thank you for the question. And I agree with Natasha Hines that the primary barrier is cost. But I do have a history of working with Indigenous health populations for my first 5 years of practice. And in that community, there's been a lot of progress. So now for urban Indigenous patients, we have Wajaywan and some really fantastic colleagues of mine working there, providing very culturally safe and appropriate care. In terms of the North End Clinic, which serves a lot of the insecurely housed and traditionally marginalized populations, a lot of African Nova Scotians in the North End community of Halifax. The biggest thing which MF mentioned is we really tailor the care to the patient. We go to where they are. We're very low barrier. A lot of our patients have a history of distrust with any sort of government or institution. And so a lot of our nurse practitioners on the street are just in regular jeans and t-shirts. They're very approachable. We have a lot of patients who we hire from within the community. And so we've worked really hard to be able to bridge that gap between kind of like a physician and a patient who might be insecurely housed. In terms of the newcomer clinic, as Dr. Brooks mentioned, copper IUDs are the preferred for many of my patients. The health authority actually does purchase in bulk some copper IUDs. So in terms of refugee claimants and government-assisted refugees, the newcomer clinic were able to provide them. The IFHP, the Interim Federal Health for Refugees, does cover the Mirena and the Nexplanon, but a lot of times for cultural reasons, they prefer not to have changes in their periods or amenorrhea. Unfortunately, though, many of my patients have significant iron deficiency, and the copper IUDs often is not the best choice for them, so there's usually quite a bit of education around that. The North End Clinic and the Newcomer Clinic were blessed at both locations to have OBS-GYN colleagues come and have gynae clinics. And so particularly at the Newcomer Clinic, there's significant education from the excellent gynae residents that volunteer their evenings.
So that concludes the first round. The next round will be 7 minutes, and we'll start with the NDP, MLA LaChance.
Thanks very much. I wanted to look at one aspect or one impact of not providing barrier-free access to contraception in Nova Scotia. So I do note, Dr. Strang mentioned it, Ms. Burgess and I have had many conversations about gender-affirming care in this province. We still don't, for a reason that no one has ever explained to me, actually meet the WPATH Standards of Care version 8. So there are still about 4 procedures which MSI does not cover in this province. I don't know why. My concern around that is that I think that really perpetuates experiences of transphobia and health disparities in the health system. It sort of says, like, we're going to give you some of what you need, some of what the international experts have said you need, but we kind of still doubt you and doubt your needs. So we're just going to hold back on some procedures. And so I also think that, you talked about trans folks accessing contraception as part of their gender-affirming care journey. So I'll open it wide for 1 or 2 responses perhaps, because my colleague has another question. But what is the impact on someone's gender-affirming care journey if they are not able to access barrier-free contraception as part of that journey?
Ms. Ferguson? It takes a second.
I did the thing. Yeah, I can speak to that. So Halifax Sexual Health provides gender-affirming care. We also handle contraceptives and PrEP, so pretty much anything we're speaking about today is relevant. So when we are talking about the cost of hormones, that may or may not also be on someone's gender-affirming care journey. We are looking at anywhere around like $75 a month for a vial of testosterone, for example. Gender-affirming hormones also fall to the same consequences of the poor family pharmacare sort of setup. So high copays and deductibles that don't actually successfully meet people's needs. So then we're adding any type of contraceptive on top of that. So we will sometimes suggest hormonal IUDs or things like Depo-Provera injection contraception as a way to prevent menstruation for folks who may be uninterested or counterindicated to actually taking hormones like testosterone, which will also usually prevent their menstruation. So we are seeing the impact of gender dysphoria, which increases rates of suicidality in the gender diverse and trans population on top of the sort of cost barrier. So all of those things are at play at once.
Emily Lachance. Oh, Emily Wilson.
Thank you, Dr. Brooks and Dr. Yoshida. You've highlighted some of the elephants in government. We know that Eastern Zone has physicians willing to provide procedure abortions, and they're still not being provided. We asked in the spring sitting why that was happening. We never got a clear answer, but we'll continue to ask. One of the other elephants, I think I call it a pink elephant. So we know that PrEP is cost effective. The evidence supports it, that people are not getting care. It prevents HIV. Yet we, Dr. LeChance has put in bills 2 years in a row asking for PrEP coverage. So Dr. Wilby, outside, there's the business case, there's the clinical case, yet we still can't convince government to provide PrEP. Do you think transphobia and homophobia has anything to do with this?
Dr. Wilby.
It's a great question. And I think if you look at the actual policies and how things are written, you do see transphobia and homophobia written, especially within how pharmacare guidance is provided. So right now, someone can have the pharmacare benefit or potentially have the pharmacare benefit if they are a gay bisexual man who has sex with men, or transgender women, person who injects drugs, or a heterosexual serodiscordant couple. The issue with that is non-binary people are not represented. Trans men are not represented, and PrEP is effective for anybody. And so in my experience in terms of these policies and these guidelines is that there is embedded systemic oppression within them, and we need to relook at that to make sure that all of our patients are represented and are able to actually receive that medication and benefit.
Emily Wilson.
Dr. Hawker? Sorry, Chair.
Oh, sorry. No, thank you for letting me know, Dr. Hawker. Dr. Hawker.
Thank you, Dr. Wilson. I just wanted to add to that, many of my patients who inject drugs similarly would benefit from PrEP, but the current pharmacare exception status criteria is too limited. And so not only is there stigma around possibly people in the pride community, but also a lot of stigma for a lot of my patients who inject drugs. And lastly, I think the big theme for today is looking at all these providers and how we're making do and trying to provide the best for our patients. We're all relying on beg, borrow, and steal and donations, and really these are services that should be funded by the government.
Emily Wilson.
Turn to my colleague.
Sorry, Emily Leisha.
Sorry, we're just keeping you on your toes today. I mean, I think just to pick up on that, I mean, it is truly appalling that we don't provide barrier-free access to contraception and that we don't have really barrier-free access to all kinds of abortions across this province. And I can't quite believe that we're sitting here talking about this in 2025. One of my dear friends was Dr. Pam Brown, who helped found the Halifax Sexual Health Clinic in the 70s. You know, so we talked about the, you know, this worry about sustainability of finding $8.5 million in the budget to provide contraception. And I guess, you know, maybe Dr. Brooks or Dr. Yoshida or someone, what's your response to the claim that the province might not be able to afford to deliver free birth control?
Dr. Brooks.
I would say we can't afford not to. We know it's going to save money. Like, even if we got nothing from the federal government, if we put the money in there, we'll get it back plus some. So the money from the federal government is a bonus, really, in this equation. So to fund it, and when you look at the budget of healthcare, we put this in one of our reports from Access Now. It's like 0.1% of the budget in healthcare to do this, and it will drastically improve access to sexual health services for people with a uterus in this province. So I would just say we can't afford not to.
Order. And before I go on, just to let you know, the reason I say people's names second is not for them to talk up, it's for Ledge TV. Dr. Hawker knows she's been here many times. I'm saying, put her mic on. But I should have mentioned that because sometimes I have to at multiple. So Emily Mumbercat?
Yeah, thank you, Mr. Chair. So I'm going to talk about reproductive coercion. And as we know, free accessible contraception helps. And we've heard a little bit about this today. There was an example, helps to protect people from this situation when someone tries to control their decisions around pregnancy or birth control. When cost isn't a barrier, it's easier for people, of course, to make choices that are right for them safely and privately. This is about giving people choice, ultimately, and control over their own bodies. So my first question is, what forms of reproductive coercion are you seeing in your work?
Who specifically, or are you leaving that open? Oh, Ms. Hines.
Hi, thanks for your question. So we know that intimate partner violence is an epidemic here in Nova Scotia, and it is said that women in Canada or people with a uterus in Canada who face intimate partner violence are 2 times as likely to experience an unintended pregnancy, and 1 in 4 Canadian women self-report not being able to freely make their own reproductive choices. What that can look like, I guess, just to paint a picture of that for you is, say, for example, if somebody has private health insurance, but it's through maybe their spouse's employer. So maybe they have spousal coverage for their prescriptions. Then if they try to go and fill a contraception prescription, their partner will know. So they don't have that freedom, that autonomy, and that confidentiality that they may need to exercise their own right to govern their own body and make choices about their reproductive health.
Emily Mumbercat?
Oh, no, we have somebody in the mic.
Who's got their hand up? Oh, Dr. Hawker. Apologize.
Yeah, I just like to add to that. I see reproductive coercion and intimate partner violence on a fairly regular basis, certainly a lot more common than I would like to see. I actually had a patient a few years ago where the partner forcibly removed the IUD. So when talking with patients, sometimes we're talking about maybe not what's the best option for that patient, but what's the option that the partner will be unaware of. So can you get to the clinic every 13 weeks to get a depot injection? If you have an IUD, is the partner gonna feel the strings, and does that put that person at risk? Or the implant, for example, is easily palpable and there's a small scar there, so the partner might know. At the newcomer clinic, sometimes we see partners insisting on coming and acting as the interpreter for their female partner, and we are sometimes creative in giving that space so that our patients can have privacy, so that we can ensure that they're speaking for themselves and that they have professional interpreters at all times.
Emily Mombercat.
Thank you. And I guess I have some questions here, but I have other questions that popped up since your answers, since you gave your answers. But again, I guess it comes to sufficient protections and reporting mechanisms around this. So, is there any, through you, Mr. Chair, to the panel? Is there anything the government could be doing to help strengthen those protections and reporting mechanisms to support folks that are going through this?
Ms. Graham.
For the cost of contraception.
Yeah.
Anyone else? Dr. Hawker?
One thing I would add is a limiting factor for many of my patients is housing. So we have a housing crisis here as well, and many times people stay in relationships longer than they would like to, or longer than is safe due to lack of housing.
Okay.
Emily Mombercat.
Thank you, Mr. Chair. And again, I appreciate this, and it's something that we hear more of. Are you seeing a rise, like in your work? I asked some questions around what you're seeing at work, but are you seeing a high volume of people coming through that are facing this? You provided a number of examples. We know it's anytime it happens, it's a problem, but you know what I mean? Like, we always look for, what ways we can support our communities and the organizations that may be facing this. So are you seeing numbers rise where people are coming in that are dealing with the situation?
Ms. Graham.
So yeah, I'm a longtime community pharmacist, and I have lots of colleagues right across the province. I'm also working in a coalition of pharmacists in the Maritime Province advocating for no-cost contraception. We are definitely seeing across the Maritime provinces and in Nova Scotia specifically, as you've heard time and time again, an increase in this epidemic of intimate partner violence, but also an increase of unintended pregnancies due mostly to cost. And I thank you for MLA Fedari for asking that question earlier, like, what are the barriers? The number one barrier is cost, and we see that day in and day out at pharmacies all across the province. People show up with their prescriptions. We say that's going to be $50, and they walk out with nothing. We are trying to bend over backwards, like the Rose Clinic and the Halifax Sexual Health Clinic as well in pharmacies. It's a little bit harder to give things out for free, which I will do, but it's a stopgap. I can only do that for so long. So we are seeing a huge rise in the front line of intimate partner the epidemic and violence and reproductive coercion, and also unintended pregnancies due to number one, no costs, due to this cost barrier, and number two, due to accessibility in rural Cape Breton and rural mainland Nova Scotia. And that's the second thing we want to work on is accessibility for contraception. But the number one barrier is cost, for sure. And then, of course, there's all other barriers that we've mentioned as well in terms of health inequities and marginalized patients. But cost is the number one concern, and we see it day in and day out at pharmacies across Nova Scotia.
Emily Mombercat, Ms. Hines is you okay? Ms. Hines.
Sorry, I'm aware of the time. I will just say that pregnancy is also extremely dangerous for people who are in situations where they're facing intimate partner violence. And it's also another form of control. And unplanned pregnancy, should it continue, does tie this person to their abuser in many ways. So unplanned pregnancies have significant implications for people who are facing intimate partner violence and puts them at higher danger.
Emily Mombercat, with 5 seconds left.
Thank you all very much. Appreciate today and the work you do.
I like better doing it on you. Emily Hill. Emily Hilton.
Thank you. I appreciate your time here today and taking notes throughout and really enforcing the meaning of the work being done here today. And Last Wednesday, Yarmouth hosted a domestic violence and gender-based violence day of awareness where we dedicated 5 purple benches through the Bar Bench program. Not just one, 5 across the county so that we could raise awareness and show support and direct people to where support was available. So it was a touching day. We had Barb Bailey's family in town along with a number of other survivors. So. And of course, we continue to grieve and heal after the events of last November at home. So again, I appreciate all the time that you've given us here today and the amount of information that you've shared. This government continues to work, on cutting red tape, which we've talked about today, eliminating the silos and the barriers that exist. So those are some of the things that I'm taking away from today, working on accessing the work across all departments of government that's happening to better care, decreasing wait times, removing or increasing rural access to care. Again, things that I'm hearing today that I want to take from today. And of course, the amazing partnerships that we have with all of you that makes this great work possible. So just knowing that the financial barriers to contraceptives, PrEP, and sexual health care services are still an issue. And this is to anyone that would like, maybe non-government witnesses that would like to comment. What are some of the non-financial barriers that the government could look to address as we move forward?
Anyone? Oh, Ms. Benoit.
The number one that we could think of off the top of our heads, as we've already spoke about here this afternoon, is access. If you can only access abortions in Halifax and Kentville, where does that leave the rest of the province? We're not just talking about access and getting to it, it is an affordability in itself. If you live in Canso or you live in Sydney and you have to drive to Halifax, that's an affordability cost of a completely different sort just to access the care you deserve.
Dr. Brooks.
I think the other thing that comes into play in rural areas for things like IUDs and implants is that you do have to have somebody to put it in. And across the country, and including Nova Scotia, women's health services tend to be poorly compensated when you compare them to services that are equally time-consuming but are only occur in men. So ensuring that providers who provide these kind of services to women or gender diverse people who need LARCs or IUD or subdermal contraceptive implants are compensated well for their time, and that these procedures aren't underfunded compared to ones that occur in men or male identifying people.
Ms. LeBlanc. Ms. LeBlanc. Marie-France LeBlanc? The one by Ms. Graham? There we go. Thank you.
I was going to wonder what you were going to say next. We talked about access, and I think it's just about as much as having the proper care at the proper places. Community health centers are very few and far between around this province. It's something that we've been working really hard to rectify and working with the government. But the community health centers are really the places where people who are marginalized, people who are underserved, trust to go in order to receive sexual health care, in order to talk about contraceptions, in order to talk about intimate partner violence. You need to trust where you're going. And there are not enough of community health centers and care facilities like ours, like the Rose, like the people that are all around here, where trusted people can go for help. And we tend to be not-for-profits, and we tend to be always on a shoestring, and we've talked a lot about donations here today, but it's very sad that we're talking about donations in order to support things that are needed. We don't have enough to provide programming, so we go out and get donations in order to provide programming. I heard someone, one of my colleagues, say that they would have to cut costs for staff in order to provide these things. We do that on a daily basis, make that assessment. So I think when you're asking about barriers and what we can do, ultimately it is a money thing, but really it's about a commitment to providing these services and to providing them in the proper way, and to talking to the experts like ourselves to say, okay, if we make this commitment, if we sign this deal and we make contraceptives free, that's great, but then how do we make sure that people are accessing them? How do we make sure that people have the education and have the opportunity? And that's a whole other conversation that we'd all love to have, I'm sure, but I think that that would be something that needs to be at the top of the list when we're talking about some of the barriers and some of the things that can be done. Thanks.
Thank you. Emily Hilton.
Thank you, Mr. Chair. In our last minute, Dr. Wilby, I'm just going to shorten the question because we're on short time. Can you speak about who is accessing PrEP and where gaps still may exist, and maybe make a comment on the pilot project that allowed Nova Scotian pharmacists to be amongst the first in Canada to prescribe PrEP?
Emily Wilby, or sorry, Dr. Wilby. Demoted you.
Maybe one day.
Demoted you.
Thank you. Thank you very much. So people who are accessing PrEP currently are people like me who have third-party insurance and who are able to receive it for about $12 for every 3 months. There is that major gap with people who really do need the medication, no matter what age group you are, no matter what background you come from. In particular, students, gay, bisexual, men who have sex with men, and transgender women, and non-binary folks, and others at risk of, as my colleagues said, persons who inject drugs. Also, we're really proud pharmacists are the first in Canada to be able to prescribe PrEP, and we hope to continue that onward and increasing access to our sexual health services overall. Thank you.
Wow, 3 seconds left. Yeah, so that concludes the questions. For closing statements, I do it a little different because I actually ask everybody. So Dr. Wilby, do you have any closing comments?
I just want to thank you all very much for having me here and for accommodating me again from Toronto. I think this is a great conversation, and I strongly encourage you to look at funding of sexual health and contraception and these services across the board, and to improve access not just for the patients but for the communities as a whole in Nova Scotia.
Thank you. Ms. Benoit. I got to surprise them because why I throw it around sometimes. You had her. There we go.
There it is. Just want to thank everyone for the opportunity to be here this afternoon, and thank you to all the presenters for their knowledge. Lastly, I want to urge everyone to consider how we can possibly not provide this service on a go-forward basis with full coverage for contraceptive care and PrEP across this province. The arguments have been made, the points were well taken, and we cannot afford not to do this. Thank you.
Thank you. Dr. Hawker.
Thank you for having us today. And one thing I haven't had the chance to mention is Access Now Nova Scotia is publicly supported by Doctors Nova Scotia, Maritime Residents Physicians, the Nova Scotia College of Family Physicians, and Dalhousie's Departments of Family Medicine, Pediatrics, and Obstetrics and Gynecology. So overwhelmingly, the experts agree that universal contraception is what this province needs. It's the best medicine. It's would improve gender and health equity. It's smart public policy and it's smart investment. And like Dr. Brooks said, we can't afford not to do it.
Ms. Burgess.
I just want to echo thank you to everyone here for sharing your expertise and your stories, and thank you for having the department here.
Dr. Yoshida.
Yeah, I'd also like to thank the committee for spending this much time listening to us and about this very important issue. And I'll just repeat again what my colleague said. We can't afford not to do this.
Dr. Brooks.
Yeah, thanks for having us. I was here in 2022 speaking to a similar topic, a little bit more broad, and then I got to encourage Nova Scotia to be leaders, because we would have been leaders then in universal contraceptions. We're no longer leaders, but let's not be laggards, right? Other provinces are doing this. Let's not drag our feet. But it sounds like we could be leaders in the PrEP field. That's not my expertise, but it sounds like Dr. Wilby's doing some amazing work and amazing research. Let's be leaders there. We can do that. We can show the rest of the country what's possible, but let's not drag our feet.
Thank you. Ms. Graham.
Yeah, want to say thank you as well. So pleased to hear positive comments from MLAs from the government. I implore you to reach out to us if you have further questions, if you have any hesitancies whatsoever in signing on to this bill or creating our own interprovincial bill. Please reach out to us. Please encourage our Premier to reach out to us, our Minister of Health, Kathleen Coleman. We would love to speak with them. We've already extended multiple invitations. I really feel strongly if we could have some one-on-one conversations. Like Natasha mentioned, please reach out to Access Now Nova Scotia. We have thought about this for decades. We know the data. We know the policies around it. We've spoken to many politicians across the country on a federal level and on a provincial level. We know how to do this. Let's not, hesitate any longer. It's already done. There's lots of precedents. We can do this in Nova Scotia. Please reach out if you have further questions.
Thank you. Ms. LeBlanc.
I would thank you for inviting us, and I would urge you to look at this in a bigger picture. Sexual and reproductive health is one portion of the whole health of a province, the whole health of an organization. We talk a lot about the social determinants of health. Funding this will have so much more of an impact on all of the other pieces that we're looking at. We're looking at housing. We're looking at all the social impacts of not supporting this. The ripple effect is large. So as a government, as a province, we've talked a lot about how we have to look at our healthcare system through the social determinants of health. That's something that the North End has been doing for 54 years. But I would urge you to look at this from that lens. This is $8.5 million that will have so much of a bigger impact in a positive way on our healthcare system. But thank you for listening to us.
Thank you. Ms. Hines.
Hi, I'll echo everything that the other witnesses are saying, but thank you so much for having us and listening to our points today. I will say that when we worry about, parts of the population that fall through the cracks, marginalized populations, unhoused, when we worry about like youth and things like that, if this benefit covered everybody, we would have to worry far less about the people that we're missing and the people that are falling through the cracks. So I hope that you will consider implementing this benefit because it really will mean a lot to a lot of different people.
Thank you. Dr. Strang.
So in my 30 years as a public health physician, certainly sexual health, and today's reminder of this, has always remained underappreciated in terms of overall health system approaches, and for many reasons, which we could talk a lot about. But it highlights lots of inequities and lots of power disparities, et cetera, in society. So lots of discussion and lots of gaps, but also opportunities identified today. But I want to end by thanking all my colleagues around here for the work that they do with limited resources addressing the sexual health needs of Nova Scotians, and also using their opportunity and their voices today to raise these issues on behalf of Nova Scotians. So thank you.
Thank you. Ms. Stockman.
So I just want to echo what everyone's saying and thank you very much for having us here today. Wouldn't it be great if we didn't actually need a Rose Clinic and didn't need to expand abortion services across the province? And wouldn't it be great if people didn't have to have an abortion to actually be able to access contraceptive? And so that really is the message, providing access before they get to the point that they see us at Nova Scotia Health would be absolutely amazing for the province.
Ms. Ferguson.
Thank you all for your questions, and thank you to my colleagues for being here today. I am really looking forward to a day in which my $17,000 is reinvested into other programming and services to meet the health needs of Nova Scotians, and I really hope that weighs on you, that we've already been providing free contraceptives for over 40 years, so that clearly shows that need has been in existence for a long time. Thank you.
I want to thank you all for coming. It's been great questions. You're excused. I'm going to give us a 2.5-minute break for them to break. We'll be back at 2.5 minutes. We're in recess. Okay, we're back to order. So I'm going to go through committee business as quick as I can because we've got some things. So there was some requests for information. Everyone would have received the response from Executive Council on the request that happened at the last committee. Any discussion on that letter? Okay. Department of Seniors and Long-Term Care. Follow-up for inquiries from the meeting of April 8th. The document's been received. Any discussion? Great. Okay, so the next thing is deferred motion. So I'm going to MLA Rankin.
Thank you, Mr. Chair. And I did check my emails today before I came in and was pleasantly surprised to see that the government has come out with supporting the motion. And this is a win for advocates. So I'll officially retract the motion because it becomes moot. The government has indeed gone forward with a roundtable. So I want to thank government. I won't celebrate it yet until I see action come from the roundtable. And I just want to say that the credit does go out to the advocates that pushed government for this. And I was simply a voice for those advocates at committee. And I think it's a great day that we'll be moving forward with the roundtable. Thank you.
Okay, can I have unanimous consent to have the motion removed? I see the unanimous consent. The motion's removed. Ledge Library Research, they were gonna. Thank gosh they didn't because we wouldn't have had time again. They will be here in July. And since the witnesses are not long, I expect we'll be able to get them done. So there's no other committee business that I haven't received any notice. So the next meeting is July 8th, 1 to 3, expansion of multidisciplinary care teams. Witnesses are Department of Health and Wellness, Nova Scotia, and we will have the librarians in library to do that. We're adjourned. See you next month.